So just to pick up on that, I trained in adult psychiatry, and then when I moved to the Maudsley, I met up with Eric Taylor. That was in 1996. And then it turned out that Brian Toon had set up an ADHD clinic with Susie Young in 1994. So that was the first ADHD clinic in the UK. And then I started working there in around 98. And in fact, my sort of background as a psychiatrist was predominantly in psychosis. I worked with sort of Mike Owen and Peter McGuffin and others on genetics of schizophrenia. And then I was looking around for another condition which I could do genetic research on. And then at the time there was a lot of twin studies coming out from people like Anita Thapar and others, showing that ADHD symptoms were one of the most heritable traits that we were looking at in psychiatry. So that's kind of really where my interest in this area came. And I continued working in the Maudsley clinic until about 2 years ago, when mainly through the work of Susie and others, I started working in HMP ISIS, which is a young prison which is predominantly with men aged 18 to 25 years of age, although now it's kind of increasing its age span up to around 30. So I'll talk about that work later in the talk. Now, a good starting point is to think about what is ADHD. And although DSM gets a lot of criticism, it does make a few sensible statements. And it does clarify that ADHD is a persistent pattern of inattention and or hyperactivity and impulsivity that interferes with functioning or development. And sort of what it isn't is really a reflection of just a behavioural problem. So although people with ADHD may have behavioural problems, they don't have to and they don't always. And certainly the symptoms or the way we diagnose it shouldn't reflect solely a manifestation of being oppositional or difficult or not understanding tasks or instructions. So it should be something that's kind of a developmental trait, if you like. Begins in early childhood in most cases, and then what we're looking at in adults is a persistent trait from childhood, you know, through to the point where you're assessing them as an adult. And the disorder is currently defined with these two kind of main symptom domains, a set of symptoms or behaviours that describe problems with attention regulation. It shouldn't really be called an attention deficit disorder, because one of the observations is that people with ADHD can be very good at certain activities. You often find people with ADHD who are very good at sports. They can stand up and be a good comedian, but they may really struggle in other areas where you need focused attention, such as sitting in a classroom, sitting in a room like this. And it really depends on the severity. I mean, one of the issues with ADHD is it's a trait, a dimension throughout the whole population. So in a way, there isn't any kind of natural boundary between somebody who does or doesn't have ADHD. And inevitably, you end up with debates about, you know, where do you draw this threshold? But of course, when it's very severe, it's very obvious. And somebody with severe ADHD is going to be very distractible. They'll describe their thoughts being constantly on the go, not being able to focus on one thing at a time, sort of thoughts that flit or jump from one thing to another. It's very hard for them to plan and organise ahead. They're very forgetful and very disorganised. It comes up in prison because some people get recalled back into the prison because they forgot to go to probation. And it really was that they forgot. And some of the sad cases are when they were actually on a job placement scheme, but they forgot to go to probation and they ended up back in the prison. So the forgetfulness in itself can cause real problems. The hyperactivity, impulsivity is kind of restlessness. I mean, when it's most extreme, somebody won't be able to sit still in front of you in the interview and may literally walk around the room or pick things up, constantly playing with their hands. But it can be less severe than that. And as you get older, often the hyperactivity does tend to decline. And so it's more a kind of relative restlessness compared to other people of your own sort of age or your own peer group. And the other big part of ADHD is being very impulsive, particularly sort of hating to wait in lines. So I typically ask people about, do you ever go to a supermarket? And people with ADHD rarely stand in a queue, and they'll avoid going shopping, or they'll go late at night when there isn't a queue. The fact that you can scan your own products in supermarkets is a real bonus for people with ADHD. So they're impatient, they don't like waiting, and then they often jump in, they often interrupt people, they often talk over people. So that's the kind of impulsive aspects of ADHD. But I think and these things are correlated, when you look at this from a scientific perspective, it seems to be largely genetic influences that sort of drive the relationship between these two domains. And around 60% or so of the genetic influences are shared, and that's why they sort of tend to co-occur with each other through development. And they have their own predictions. You can see that ADHD is going to have different impacts on people. And the inattention in particular is also linked to reading problems, but also educational difficulties. And so one of the key problems will be engaging with any kind of educational task because you can't focus and you're distractible. But then the hyperactive impulsive symptoms are more strongly linked to oppositional defiance behaviour and behavioural problems. But one of the things we've been focusing a lot on is emotional lability, because I guess clinically it's a very sort of obvious and prominent feature of ADHD, where you have a sort of unstable, volatile, affective mood state. So it's not episodic, it's not like bipolar, it's just an irritable mood state that you've had for most of your life. And it turns out that in treatment trials of ADHD in adults, you get a similar effect size on emotional lability as you do on the other two core domains of inattention and hyperactivity impulsivity. So clinically, it's very important. And there's been a number of studies showing that if you control for inattention and hyperactivity, emotional lability is an independent predictor of impairment across a wide range of sort of social and educational and other kind of outcomes. So clinically, it's important, and it responds to the same treatments as core ADHD symptoms. I thought I'd sort of, in thinking about the links between ADHD and aggression, I thought I'd just begin with this work I found very interesting from Temi Moffat's Dunedin study, where she followed up a cohort of around 1,000 people from early childhood and then with regular measurements through their life into adulthood. And what she found was a linear relationship between very early measures of self-control in infants and then serious sort of outcomes in adulthood. And when you look at the way they define self-control, it really is very similar to the construct we have for ADHD. So in effect, we're talking about childhood self-control, but it's very similar to what we would think of as ADHD. And in a rather linear fashion throughout the entire population, it predicts poor physical health in adulthood, substance dependence in adulthood, sort of poor social economic status and planning, single-parent child rearing, and over on the right there, adult criminal convictions. So you can see, although if you're in the clinical group, which is at the tail of this distribution, you will get more criminal convictions, but actually there's a kind of rather linear relationship. So even in sub-threshold sort of levels of ADHD, there'll be an increased level compared to somebody who has a low level. So in general, it's a kind of measurable risk factor throughout the population for criminal activity. But ADHD has been shown to persist into adulthood to varying degrees. And a lot of this data is based on taking children with ADHD, following them up into adulthood, and looking at the persistence rates. And one of the most cited papers was a meta-analysis from Steve Ferrone, who found that around 15% retained the full diagnosis by the age of 25, but importantly, another 50% fulfilled an impartial remission criteria where they still had high levels of symptoms and they were still impaired by those symptoms, but they didn't quite meet the full criteria under the DSM. In our own studies in the UK, and also colleagues who looked separately at this in Holland, we began with children who had a kind of more severe form of ADHD because they all had a combined subtype, which is rather more severe than taking the whole spectrum of people that have an ADHD diagnosis. And when we followed them up into young adulthood, we actually see a somewhat higher persistence rate of about 80%. So it might reflect a kind of rather more conservative approach to diagnosis in UK and in Europe, where we're generally diagnosing more severe cases than perhaps they are in the US. So we see very high persistence rates. And overall, the prevalence of ADHD is, from epidemiological surveys, is thought to be in the order of 2.5 to 4.5%, so let's say 2 to 3%. So how do we think about the links between childhood ADHD and behavioural outcomes? And so a lot of people would argue that, well, of course, you had ADHD as a child, and so for various reasons that puts you at risk of developing these other problems later in life. So, for example, criminal behaviour, aggression, conduct disorder during childhood, emotional instability, and that these things could also be linked to development of personality disorder and substance abuse, which all occur at higher rates in ADHD. And there's been a lot of focus on thinking about sort of what happens to you as a child. So there's educational failure problems. People are often not doing well at school, or they may be under detrimental influences from peers. There's often poor parental supervision or even abusive parenting. And then exposure to substance abuse, conduct disorder problems, and specific and general learning difficulties. So many risk factors that kind of are seen in children with ADHD that could cause these further problems. There was also an interesting set of findings from Anita Thapar looking at genetic risks that may also play a role. And in their initial study, what they found was that in a clinical sample of children with ADHD, if you had a particular genotype of the COMP gene that led to low dopamine levels, you were more likely to have conduct disorder symptoms as a child. But then in 2 subsequent samples, using epidemiological data sets, they found there was no effect of this gene on any kind of measure linked to aggression if you didn't have ADHD. The risks were only for children who had ADHD. And so in the second study, they found that if you had this COMP gene, you were more likely to have adult criminal convictions. And in the third study, you're more likely to show aggressive behaviour, but only if you have ADHD. So ADHD is an under kind of background risk factor, if you like, for developing these problems. So the other thing to think about is to what degree persistence of ADHD itself is linking to these kind of behaviours. And so, for example, when ADHD persists, there are a lot of traits that are associated with the persistence of ADHD itself: inattention, hyperactivity, emotional lability, the impulsiveness, self-regulatory problems, and novelty-seeking risk-taking behaviour. So one way of testing for this, of course, would be to treat the ADHD symptoms, because we know that drug treatments reduce ADHD symptoms currently, and then see whether there really is an impact in reducing criminal behaviour, aggression, and so on. And that would tell us that, yes, it's an important, the current level of ADHD is also an important component here. And we now know a fair amount about how to diagnose and treat ADHD. We have clinical guidelines, particularly the NICE guidelines, and other documents from Europe and from David Nutt's organisation, the British Association for Psychopharmacology. And these guidelines are all very similar in the recommendations they give. And essentially, for treatment of ADHD in adults, they say that drug treatment should be initiated first, rather than non-drug treatments, unless the person would prefer a psychological approach. That methylphenidate is currently recommended as the first-line treatment, whereas atomoxetine or dexamphetamine is thought of as a second-line treatment. Although the evidence is perhaps may change in the future. Dexamphetamine is a very effective drug. There's now a new, very safe, sustained form release of dexamphetamine called lisdexamphetamine, which is a very safe drug to use. And atomoxetine, there's a lot more data on atomoxetine that's been emerging. And then you would also think about using psychological treatments as an adjunct to those drug treatments, particularly if there are residual impairments and difficulties. And I have to say, when we come to thinking about offenders, it does seem that some kind of psychological support is really critical to the whole process. That it rather, when you treat somebody with ADHD, it can actually sort of focus their mind on their problems and that's not always something that people like. And so they actually need a lot of, they do need some support and help through that treatment process. And what are the kind of effects we see when we treat people with ADHD? And typically, people say they're more able to focus, they can complete tasks more easily, their mind wanders less, and it helps them a lot, particularly in education and in planning for the future. They feel less restless, and this is both less mentally restless but also physically less restless, and they often sleep much better. So one of the problems in ADHD is people find it hard to get off to sleep because their mind's so active or they're physically so restless at night time. They describe their moods being much more stable, so they feel calmer and they're more in control of their emotional reactions. And overall, they're more in control. There's more self-control. They're less impulsive. They can stop and think before they act more easily. And these are very sort of characteristic effects of stimulants. Now, in the general literature, looking at non-offender populations, we can see there's been a lot of treatment trials of methylphenidate in particular. And the average effect size in most of these studies averages out at about 0.5. And interestingly here, they've separated out a small number of studies at the bottom where they had comorbid substance abuse. And in fact, in those studies, they weren't able to show an average effect. In fact, there wasn't a useful clinical effect in this group with comorbid substance abuse. And there may be a lot of reasons for that, which I can't discuss today. But certainly the average effect size is about 0.5. If you do the same kind of studies looking at atomoxetine, you get a similar effect. The average effect size is a little bit smaller. It's about 0.4. So until recently, there were very few studies in offender populations. And this was put right with the only, as far as I know, it's the only published RCT study within an offender population. And this was a prison population in Sweden. They were quite people with very severe forms of ADHD, and they were long-term prisoners. So they'd done quite serious crimes that had led to long sentences. And within that context, and this was a very small sample because they only had 15 in each group, 15 on drug, 15 on placebo. But what you'll see is that over the first 5 weeks, which was the RCT part of the study, there was a huge clinical effect, and that's mainly because there was no placebo effect. I mean, this is actually very unusual. You normally get a 20 or 30% placebo effect in treatment trials of ADHD. But in this severe offender group, there was no placebo effect. And then when they, after 5 weeks, switched the group on placebo onto the medication, you can see that they again had a sensible treatment effect. So they ended up with an overall effect size of about 2.1. It's a massive effect size. So we don't know if this would generalize to other offender populations, but it does seem to indicate that we would expect to see good effects in offender groups. And so the other key study has already been mentioned by David Nutt, which was this epidemiological study from Sweden, where they can pull together national, very well kept and highly representative national databases. So they can pull together prescription databases, diagnostic databases, and also criminal records. And so they were able to look at the risk of having a criminal conviction over a 4-year period. But they were also able to control for being on and off medication by comparing times when you were being treated with times when people were not being treated. And they defined treatment as a period of 6 months of continuous prescribing. And so first of all, you can see there are big case control differences. So almost a 6-fold higher rate of criminal convictions if you had ADHD compared to people who didn't. And then, as David said, when you treated people with ADHD with medication, there was a marked reduction, about 32% reduction in criminal convictions in men, and a slightly larger effect in women. But the finding I found most impressive was actually looking at the effect of an antidepressant, which was prescribed at equally high rates in this sample. And there you can see there's no effect at all. So this effect on reducing crime criminal convictions was specific to the ADHD drugs and not to another drug like an antidepressant, suggesting it wasn't just the non-specific effects of being engaged in the treatment process. As when we think about the rates of ADHD in offender populations, the best data at the moment really comes from looking at prison populations, and Susie Young put together a meta-analysis that tried to focus on studies where they hadn't just used rating scales, but had also gone through a full diagnostic assessment to get a more accurate estimate of prevalence. And essentially, across men and women and at different ages, the prevalence rate was rather high, and in the order of 20 to 30% for men and women, and also at different ages. So that's the kind of level that we're expecting to see, and then we can see what we found in our own samples. Susie Young had earlier done a prevalence study of ADHD within secure mental health units. And this was a small study. It used rating scales, but it was the first study of its type at the time. She'd looked at 69, she identified 69 offenders with a mean age of 34. The primary diagnosis was personality disorder, and they excluded people who had a severe learning difficulty or a severe mental illness, and then looked at ADHD and some other behavioural outcomes. And overall, what she first of all found was that there was a very high reporting of ADHD symptoms retrospectively in childhood. So these adult offenders, 78% of them recorded very high levels of ADHD symptoms as children. But when she looked at the diagnostic rates, 4% met the full criteria, and 29% met this sort of impartial remission. So they were just sub-threshold to the full criteria, but still had significant and high levels of ADHD symptoms. So overall, around 30%, about a third of this population sort of met ADHD criteria. They went on to look at the links with data, first of all using a scale called the DBSP, which was sort of measured by the prisons, by the staff. So it was and sort of observing the behaviours of the people under their care, and in fact didn't really find very much using those healthcare sort of rated observations of behaviour. On the other hand, when they looked in the records and looked at objective measures of the number of critical incidences, they did find differences. Although because the sample's small, there's overall not much in the way of significance, but there were statistically significant effects for the mean overall incidence score, so roughly twice as many critical incidences, but also almost twice as many acts of verbal aggression, and also many more examples of damage to property. So overall, there was evidence of an increase in critical incidences in this sort of ADHD group compared to this non-ADHD group. But this is all based on rating scale data. So we came back to this more recently, and this is work that's not yet been published. And so working at Broadmoor and Riverhouse, at the time we identified 341 potential patients, 241 here at Broadmoor, 100 at Riverhouse. In fact, the number that came into the study was relatively small. Partly 68 were excluded for being too severe to kind of come into this study. Perhaps we couldn't get the measures, or because their behaviour was so difficult. So there was 68 excluded for that reason. And then out of 246 who we could have worked with, 115 refused to take part. So it's quite hard to do this kind of research, we found, in this sort of population. And so in the end, we screened 131 people. We found that about 20% of those screened positively for ADHD. And then when we did a diagnostics assessment, we found that around 10 of those met clinical criteria for either ADHD or just being sub-threshold to the criteria. So overall, a prevalence rate which was just slightly higher than the population rate, 8.6%, so perhaps sort of two to three times the population rate. But when we separated out the samples into those with a serious mental illness and those with a primary personality disorder. Here we saw big differences because we actually didn't find any ADHD among 79 people with a severe mental illness, whereas so all the ADHD was found within the group who had a primary personality disorder. So you can see sort of 8.7% met full criterion, 13% met ADHD in partial remission. So that's really the group one would want to think about and target when you're thinking about ADHD in this kind of population. So I'll quickly go over these studies. I mean, if you ask people to rate their own levels of impairments, people with ADHD or people screening positively for ADHD in Broadmoor and Riverhouse score themselves as being much more impaired across a whole range of social and functional and educational domains. But we were most interested in the number of critical incidences recorded in the prison records or the hospital records. And again, because here the sample is really quite small, we only had 10 cases that actually ended up meeting our criteria in this study. And so so we had trends, but not significant effects here. But you can see that it looks as if you've got almost twice as many critical incidences in total. Most of those are no harm incidences. I mean, there's quite a low level of harm incidences being recorded in the records during this study period. And also there's an effect on the time in seclusion. Although when you actually look at the data, it seems you've got 1 or 2 individuals with ADHD who are causing a particular severe problem and spent a lot of time in seclusion that kind of rather weighted this data. So this is at least preliminary data showing that there may well be more problems managing the people with ADHD than the people without in this sort of population. So most of our work has now been in a prison setting, and I realise I've only got about 5 minutes left for this. So I will have to go through this fairly quickly, but we're working in a prison, so these are young offenders. The sentence periods are usually between around 6 months to 2 years. So they're all people who are coming out into the community in the very near future, and we're very keen on working with them both in the prison but also tracking them and following them in the community. This initial study was an open clinical trial, and we're now very hopeful of getting funding to do a placebo-controlled trial. So, but this is all open trial data. And essentially what we did, this is as of September when we last looked at the, analysed the data. We'd screened 1,800 prisoners. We found that 25% of those people screened positively for ADHD. And after doing a full ADHD assessment, we found that 78% of those patients met full criteria. And we ended up with an overall estimated prevalence of 19.6% of offenders in this institute met ADHD criteria. And out of those, we've treated 117 of those people, which is 42% of the people we diagnosed with ADHD agreed to come into this trial. So we ended up treating about half of them. Just an aside, we also were very interested in people's reported use of drugs in the community. And what we found is that the group a group that had ADHD compared with a group that didn't were much more likely to use cannabis, and in particular use it on a daily basis. So 71% used it daily compared to only 37% who didn't have ADHD. And the only other, there was no difference, significant difference with alcohol use, but there was with stimulants. So again, they're twice as likely to use stimulants as a non-ADHD group among this offender population. And so we are very interested in, particularly in the cannabis, because so many people do report that they feel calmer. Some people say, I get to work, but I have to have a spliff first. You know, without it, I'm not calm enough or settled enough to turn up at work. So there may well be some treatment effects that we need to understand better. But when you use ADHD drug treatments, and so this was done in a very controlled way. We titrated every week to try and get a sort of an optimal effect, and then followed people up to 12 weeks. But what you see is a very big effect. I mean, the effect size here in the pre-post analysis is about 2. And what we worked out that is if 20% of this effect is due to the drug rather than non-specific placebo effects, that would meet the average effect size of 0.5 from RCTs in the general population. So we only need 20% of this effect to be due to drug to get the same findings we'd expect. So that's for ADHD symptoms. But if you measure emotional dysregulation, and so this would be mood fluctuations, affective lability, temper control, and emotional overreactivity, measured by an interview rating from the investigator talking about these symptoms with the patients. You actually get a very an effect size which is similar across all these different subscales of emotional instability, but also is very similar to the effect size you see for stimulants, which is what previous studies had shown. We also used a measure called the Maudsley Violence Questionnaire, and here, interestingly, you got significant improvements for the Machismo scale. And this seemed to sort of reflect a change in a kind of the way that people would envisage the way they would react in a situation where violence might occur. And they seem to sort of stop and reflect and are much less likely to act. And there's a kind of change in the way they approach and think about this that's captured by this scale. The more objective data was looking at the number of critical incidences recorded by the prison staff. These are prison officer records. And so what you see over this 12-week period is a roughly half the number of total critical incidences over a 3-month period compared to the previous 3 months. But also, and in fact uncorrelated, you see an improvement in what they call positive IEPs. So they're getting marks for good behaviour, engaging better with the whole process within the prison, and that's roughly doubling. So again, perhaps it's less certain that these effects are due to the drug. We're more confident that the symptom effects are, and that would really be the big reason to do an RCT. You know, do we see proper drug effects on these kind of behavioural outcomes? So going forwards, I mean, to us doing an efficacy study within the prison is critical because people are very impressed by these data, but one of the big questions from the governor and others is, but can we say it's the drug effect, or is it something else to do with, you know, just engaging with them? You know, we meet them every week and they get a lot of support by being in these trials. So is it really the drugs that are improving behaviour? And so we can only answer that with a proper RCT. So we're hopeful we can do that. But the bigger question is really long-term effectiveness. So we've got the nice studies from Sweden, but we would need to show experimentally in some way that this really is meaningful. And so the ideal would be to have a control group and people who are in treatment and to really follow these people up in the community. Can we engage with them? Will they take the treatments in reality in the community? And will it really impact on aggression and behaviour, attendance at probation and other things that are needed in this population? So I think that's the challenge. So I just wanted to end up with a few summary points. You know, ADHD is a behavioural syndrome, including hyperactivity, impulsivity, and emotional dysregulation. It's often comorbid with personality disorders, particularly in forensic mental health, you know, rather than with psychosis or bipolar and so on. Emotional lability responds to stimulants and atomoxetine, and I haven't shown you all the data on that, but there's a number of studies demonstrating that. From my point of view, I'd expect that reactive forms of aggression are going to show the most benefits from this kind of intervention. And I feel that in trying to understand the impact of treatment on more instrumental forms of aggression, I'm much less certain about what to expect. And there's really no data yet that's kind of separated out these different types of aggression and looked at the effects of treating ADHD on that. So overall, there clearly is a need for better understanding the role of treating ADHD in offenders with primary personality disorders and without. So thank you.